Hello friends, welcome back to my YouTube channel. This video is all about renal system. First, talking about renal clearance, it is the rate of plasma being cleared. Clearance equal to UXV by PX. U means urine concentration in mg per ml. V means flow rate of urine. P means plasma concentration in milligram per ml. So clearance is urine concentration into flow rate of urine divided by plasma concentration. Next is GFR. GFR, clearance from glomerulus, which is freely filtered from Bowman's capsule. It is not reabsorbed, it is not secreted. Clearance more than GFR is eventual excretion more than filtered, that is tubular secretion. If clearance less than GFR, that means it is reabsorbed. Clearance of PAH is maximum filtered by GFR, then there is tubular secretion. RPF is renal plasma flow. It is to estimate clearance of PAH. Inulin helps in free filtration. There is no reabsorption, there is no secretion. So renal clearance is done to measure the rate of plasma being cleared. So the order of clearance is PAH more than creatinine, more than inulin, more than urea, more than sodium, more than glucose. To estimate GFR, we should measure the inulin level. Creatinine gives estimated GFR, that is eGFR. Urea clearance, if it is less, it is reabsorbed by PCT mainly. 100% of glucose, if reabsorbed, it is seen in patients with normal glucose level. Next, about hyperglycemia. Glucose reabsorption happens via SGLT2 if glucose is more than 375 mg per minute, that is TM. All transporters are saturated and excretion happens. When glucose level is 200 mg per minute, that means it is the renal threshold. When glucose reaches 200 mg per minute, then renal excretion of glucose starts and glycosuria begins. Difference between the above two cases, like if glucose is more than 375 mg per minute or if the glucose is 200 mg per minute, what happens is it is the splay phenomenon. RBF is renal blood flow. How to calculate renal blood flow is renal plasma flow divided by 1 minus hematocrit. Filtration fraction is GFR divided by renal plasma flow. Counter current mechanism include counter current multiplier as well as counter current exchanger. Counter current multiplier is by the loop of Henle main structure which creates concentrating segment in medulla and it reabsorbs water. Counter current exchanger is maintenance by vasa recta. Next is renal physiology. Net filtration pressure is hydrostatic pressure of glomerulus along with oncotic pressure of Bowman's space. Oncotic pressure of glomerular space opposes and favors the filtration. Oncotic pressure of glomeruli doesn't favor filtration. Bowman's space, there is hydrostatic pressure against filtration and oncotic pressure favors filtration. Net filtration pressure is calculated by PGC plus oncotic pressure of Bowman's minus PBS plus oncotic pressure of glomeruli. That is, net filtration pressure is pressure of glomeruli plus oncotic pressure of Bowman's minus pressure of Bowman's plus oncotic pressure of glomeruli. Net filtration pressure towards filtration of substances is 10 to 15 millimeter. In afferent arterial constriction, GFR reduces, renal plasma flow decreases, filtration fraction decreases or there is no change. In efferent arterial constriction, GFR increases, renal plasma flow decreases, filtration fraction increases. High plasma protein concentration, GFR decreases, renal plasma flow there is no change, filtration fraction reduces. In low plasma protein concentration, GFR increases, renal plasma flow there is no change, filtration fraction increases. Ureter vasoconstriction, GFR decreases, it can cause renal failure. Renal plasma flow in ureter vasoconstriction there is no change. Filtration fraction in ureter vasoconstriction reduces. Prostaglandins dilate afferent arteriole. It increases renal plasma flow, increases GFR. There is no change in filtration fraction, which is blocked by NSAIDs. So NSAIDs decrease GFR. Angiotensin 2 constricts efferent arteriole, decreases RPF, increases GFR, and increases filtration fraction. It is blocked by ACE inhibitors. So, ACE inhibitors decrease GFR. NSAIDs and ACE inhibitors, this causes pre-renal acute kidney injury. Next, about PCT, proximal convoluted tubule. Here sodium, glucose, urea, bicarbonate reabsorption takes place. Glucose reabsorption, there is glucose reabsorption as well as sodium reabsorption. It is because of the help of SGLT2. It is unidirectional. Sodium and glucose, it goes out. It is unidirectional in same direction with the help of ATP. Sodium HCO3 reabsorption, there is sodium H plus by exchange channel. It is bidirectional. So sodium H by exchange channel. H2CO3 reabsorption doesn't take place here. Here base reduces, it forms metabolic acidosis. Defect with this channel causes renal tubular acidosis, that too type 2 renal tubular acidosis, which is proximal renal tubular acidosis. H plus HCO3 is H2CO3. When carbonic anhydrase acts on it, carbon dioxide plus H2O, it causes H2CO3. Then again H goes out and it forms HCO3. So H2CO3 reabsorption, when it doesn't takes place, we give carbonic anhydrase inhibitors like acetazolamide. Next, about thin descending loop of Henle, it is the concentrating segment of tubule or nephron. Thin descending loop of Henle, here it is permeable to water, which allows for water reabsorption. Next, about thick ascending loop of Henle. Thick ascending loop of Henle is the diluting segment. Here the drug acting is loop diuretics. The defect here is Bartter syndrome. So remember Bartter loop diuretics. Here in Bartter loop diuretics, sodium potassium 2 chloride channel, it is the one affected. So sodium potassium chloride reabsorption happens here, that is Bartter loop diuretics. Bartter loop diuretics, it doesn't allow sodium potassium chloride reabsorption. The drug here we gave is furosemide. Sodium potassium chloride reabsorption takes place through paracellular transport with the help of magnesium and calcium, which is reabsorbed. Next, about DCT, distal convoluted tubule. Here the channel is sodium chloride channel. Here the drug group is thiazide. NaCl reabsorption doesn't happens by this. Here the syndrome we should remember is Gitelman's syndrome. Here also magnesium and calcium reabsorption happens. PTH is increasing the calcium reabsorption in urine and the site is DCT. About collecting tubule, the cell affected is principal cell. Alpha intercalated cell gets affected, which excretes H plus, and also beta intercalated cells are also affected. In principal cell, what happens is aldosterone causes sodium water reabsorption, potassium secretion as well as H plus secretion. It is back into the urine. Water reabsorption is via ADH induced aquaporin 2 channels. Here ADH along with V2 receptor, it causes aquaporin to attach here, and aldosterone acts on ENaC, which is blocked by potassium sparing diuretics like amiloride, triamterene, and the activation of ENaC channel, it is the Liddle syndrome. So ENaC channel, it absorbs sodium and excrete potassium. Distal RTA type 1 happens here in alpha intercalated cell, that is in the collecting tubule. So distal RTA type 1 happens in collecting tubule, and proximal RTA, proximal renal tubular acidosis type 2, it happens in PCT. Now types of renal tubular acidosis: type 1 RTA in the distal convoluted tubule, H plus excretion defect. It is also in the collecting tubule, which affects the alpha intercalated cell. Type 2 renal tubular acidosis, it is in the proximal tubule. There is H2CO3 reabsorption defect. Here there is metabolic acidosis. Type 4 renal tubular acidosis, which is the most common one, and it is associated with hypoaldosteronism. Next is about the renal tubular acidosis types. So in type 1 RTA, potassium is decreased, calcium is increased, urinary pH is increased, and nephrolithiasis it is present. In type 2 RTA, potassium is reduced, calcium is reduced, urinary pH is reduced, and nephrolithiasis is not present. In type 4 RTA, potassium is increased, calcium is decreased, urinary pH is decreased, and nephrolithiasis is not seen. So, type 1 RTA, it is associated with Sjogren's syndrome, which is an autoimmune disease. Type 2 RTA associated with Wilson's disease, Fanconi's disease. Type 4 RTA is associated with hypoaldosteronism, obstructive uropathy. Next, about the tubular diseases. In the thick ascending loop of Henle, there is sodium potassium 2 chloride inhibitor. I told you about the Bartter syndrome, furosemide. Here BP is reduced, potassium is reduced, alkalosis is seen, urine calcium increases. DCT, there is sodium chloride channels which inhibits. This is Gitelman syndrome. Here BP is reduced, potassium is reduced, alkalosis is seen, urine calcium decreases. Sodium chloride channels by the DCT, if there is gain of function mutation, it causes Gordon syndrome. There is BP increase, potassium increase, acidosis, and nothing happens with urine calcium. Next, about collecting duct, about the INAC channels. If INAC channel is stimulated, it causes Liddle syndrome. Here BP is increased, potassium is decreased, and there is alkalosis. Urine calcium, there is no change in Liddle syndrome. When INAC channel is inhibited, there is pseudo-hypoaldosteronism. BP is reduced, potassium is increased, and acidosis is seen. Here in pseudo-hypoaldosteronism also there is no change in urine calcium. Next, about 5 diuretics. So first, about osmotic diuretic, which is mannitol. Mannitol is used for cerebral edema as well as angle closure glaucoma. Mannitol is contraindicated in pulmonary edema because it increases preload. Acetazolamide, it is an carbonic anhydrase inhibitor which is acting on PCT. Side effects of acetazolamide is type 2 RTA, which is proximal RTA, NH3 toxicity, sulfa allergy, hypokalemia. All these are side effects of acetazolamide. Loop diuretics, it is the furosemide. It acts on the ascending loop of Henle. Side effect of loop diuretic is ototoxicity, dehydration, sulfa drug allergy, metabolic alkalosis, decrease in potassium, decrease in magnesium, urine calcium is increased, gout, interstitial nephritis. Thiazide decreases urinary calcium, so it is used in idiopathic hypercalciuria. It is the first line drug for hypertension and it is also given for heart failure. Nephrogenic diabetes insipidus as well as osteoporosis. Side effects of thiazides are hyperuricemia, hyperglycemia as well as urine calcium will be reduced. Next, about the collecting duct. Collecting duct, potassium will be increased, so here we use potassium sparing diuretics, that is spironolactone, eplerenone, amiloride as well as triamterene. Side effects of spironolactone is gynecomastia, anti-androgen effect as well as metabolic acidosis. Next, talking about juxtaglomerular apparatus, there are 3 cells. One is macula densa, then juxtaglomerular cells as well as Lassis cells. First, talking about macula densa, it is the cell between DCT, that is distal convoluted tubule, and thick ascending loop of Henle. Function of macula densa is it help in tubuloglomerular feedback and they are chemosensors of tubules which sense the amount of sodium chloride. When there is increase in sodium which gives feedback to glomerulus, vasoconstriction of afferent arteriole happens, then GFR decreases, sodium decreases and sodium reabsorption decreases. Mediator for vasoconstriction of afferent arteriole is adenosine. When there is decrease in sodium, vasodilation of afferent arteriole take place, GFR increases, mediator is nitrous oxide. Next, about juxtaglomerular cells. Renin-angiotensin-aldosterone system happens here. Baroreceptors of glomerulus, modified smooth muscle in afferent arteriole is present here. This juxtaglomerular cells function as it sends the glomerular filtration rate, and if the glomerular filtration rate is decreased, renin is released, and renin activates angiotensin 2, which activates aldosterone and causes increase in sodium and water reabsorption. Next is about the Lassus cells. Lassus cells is the mesangial cells. It has anti-inflammatory property. Glomerulus, there is a glomerular barrier which is the endothelial cells. There are two epithelial layers, epithelial food processes, endothelial processes, and the deposits in glomerulus are subepithelial deposits, intramembranous deposits, subendothelial deposits, and mesangial deposits. Above the basement membrane, there is the food process or podocytes, and below the basement membrane, there is endothelial cells. First, talking about the subepithelial deposits, it is the humps. Humps in children, we think about PSGN, post streptococcal glomerulonephritis. There is spike and dome pattern in elderly. It is about the membranous nephropathy. So, humps in children, post streptococcal glomerulonephritis, and spike and dome pattern in elderly, membranous nephropathy. This is the subepithelial deposits differential diagnosis. Next is intramembranous deposits. It is MPGN type 2, which has dense deposit disease. Next is the subendothelial deposits, that is MPGN type 1, that is the lupus nephritis. Mesangial proliferation, it is seen in IgA or Buerger's disease. Alport syndrome, or it is the defect in type 4 collagen. There is basket weave appearance of basement membrane. In type 4 collagen disease, there is alpha 3, alpha 4 and alpha 5. Alpha 5 is the Alport syndrome. Alpha 4, it is the familial disease, thin basement membrane disease, which is also known as benign familial hematuria. This is the alpha 4 collagen disease. Next, about alpha 3, it is the Goodpasture syndrome. Anti-glomerular basement membrane antibodies are present, which causes hematuria. Hemoptysis is also present because pulmonary capillaries are affected. It is an example of renopulmonary syndrome. Differential diagnosis is microscopic polyangiitis, vaginous granulomatosis. Next, about Alport syndrome. Alport syndrome, we can see anterior lenticonus, sensorineural hearing loss, and in kidney there is basket weave appearance of basement membrane as well as hematuria. Loeys syndrome is posterior lenticonus. Oculocerebrorenal syndrome is associated with Loeys syndrome. Next, about nephritic syndrome, hematuria. Hematuria, there is cola colored urine, and in microscopy we can see dysmorphic RBCs and RBC cast. This is about nephritic syndrome. A child presenting with hematuria which started 10 to 21 days, that is 2 to 3 weeks after pharyngitis or empatico. This is a post pharyngitic condition. Most common cause is post streptococcal glomerulonephritis. On light microscopy, there is proliferation, inflammation as well as inflammatory cells present. Here there is subepithelial deposits or humps. Immunofluorescence, there is C3 and IgG deposited in a granular fashion. This is about PSGN, post streptococcal glomerulonephritis. In case of adults, there is IgA nephritis or Buerger's disease. It is synpharyngitic, that is, patient will be having this symptoms 3 days after pharyngitis. There will also be hematuria, recurrent gross hematuria present. Mesangial proliferation, in immunofluorescence we see IgA deposits on mesangium. Rapidly progressive crescentric glomerulonephritis, we can see crescents formed of fibrin and WBC, which is mainly affecting the parietal epithelium. Next, about nephrotic syndrome. Patient will be having frothy urine, lipiduria which shows Maltese cross appearance. Patient will be edematous, proteinuria more than 3 gram per deciliter, hypoalbuminemia. All these things should be remembered in nephrotic syndrome. This Maltese cross is also talked in two other conditions, babesiosis as well as Fabry's disease. So here in nephrotic syndrome there is frothy urine, lipiduria which shows Maltese cross appearance. First, about minimal change disease. Minimal change disease is seen in children. On light microscopy, it is normal. Minimal change disease symptoms are prior to upper respiratory tract infection, immunization using NSAIDs. Minimal change disease has association with Hodgkin's lymphoma. Minimal change disease has association with nephrotic syndrome. On electron microscopy, minimal change disease shows effaced food processes, that is there is effacement of food process. Next is about FSGS, that is focal segmental glomerulosclerosis. It is seen in adults associated with reflex nephropathy, obesity, sickle cell anemia using heroin, HIV. It is a collapsing variant in HIV. So this is about FSGS. In FSGS, there is nephrin, that is the NPHS1 Finnish type, which is the steroid resistant MCD or FSGS. It is associated with congenital nephropathy. Next is about the membranous type of nephrotic syndrome. It is most commonly seen in elderly. Subepithelial deposits are seen, which is spike and dome pattern. Risk factor for membranous type is adenocarcinoma lung, colon as well as melanoma. PLAR2 is the associated thing with membranous type. There is association with phospholipase A receptor 2 mutation. Next is about MPGN. It is seen in adults. MPGN is membranoproliferative glomerulonephritis. It is seen in adults. It is associated with HBV, HCV, malaria. There are two types. Type 1 membranoproliferative glomerulonephritis. It shows tram track appearance. Thickening and splitting of basement membrane is present in MPGN. Type 1. Type 2 MPGN, there is dense deposit disease. It causes membranous deposition. On electron microscopy, there is thickening of membrane and intramembranous deposits are seen here. C3 plus as well as C3Nef plus deposits are seen. Next about AKI versus CKD, acute kidney injury versus chronic kidney disease. So first, in acute kidney injury, corticomedullary differentiation is maintained. Cortex is dark hypoechoic, pyramid is hyperechoic. Size is maintained in acute kidney injury. Urine osmolarity in acute kidney injury, it is variable on pre-renal and renal type. In acute kidney injury, there is no anemia, there is no metabolic bone disease. In acute kidney injury, the renal type or acute tubular necrosis, there is presence of granular cast or tubular cast. Next about the CKD, chronic kidney disease, corticomedullary differentiation, that is CMD, it is lost. Size is contracted. Urine osmolarity, it is fixed. Here there is isostenuria, that is specific gravity is at 1.010. In CKD, erythropoietin deficiency is present. In CKD, there is metabolic bone disease present. There is association with secondary hypoparathyroidism as well as renal osteodystrophy. In CKD, there is waxy or broadcast present. Next about pre-renal as well as ATN, acute tubular necrosis of AKI. First about pre-renal causes of AKI. The fractional excretion of sodium is less than 1%. Urine sodium is less than 20. Urine osmolality is high. It is more than 500. There is no urine cast in pre-renal AKI. Urea creatinine ratio is more than 20:1 in pre-renal AKI. Pre-renal causes are shock as well as hepatorenal syndrome. Next about acute tubular necrosis, fractional excretion of sodium is more than 1%. Urine sodium is more than 20. Urine osmolality, it is low. Urine osmolality is less than 350 in acute tubular necrosis. Muddy or brown granular or tubular cast is present in acute tubular necrosis. Urea or creatinine ratio, it is less than 10:1 in acute tubular necrosis. Causes of acute tubular necrosis is sepsis, ischemia, nephrotoxins like drugs, contrast agents, as well as myoglobinuria. Biomarkers of AKI are cystatin C, KIM1, NGAL, TIMP2, IGF-BP7. Next, talking about urine cast. First is hyaline cast. Hyaline cast in urine, it is normal. It is also seen in stress, fever, increased exertion or exercise. Tom harsh fall protein should be remembered when talking about hyaline cast. Next is cola or red colored RBC cast. It is seen in glomerulonephritis. It shows dysmorphic RBCs. WBC cast is seen in pyelonephritis. Granular cast or tubular cast, which is muddy brown cast, it is seen in acute tubular necrosis. Broad waxy cast is seen in CKD. Next, about renal pathology. Waxy kidney is seen in amyloidosis. Flea-bitten kidney causes are rapidly progressive glomerulonephritis, PSGN, as well as malignant hypertension. Leather grain kidney is associated with hyaline arteriosclerosis, which is noted in diabetes mellitus. Cystic kidney, it is seen in autosomal dominant polycystic kidney disease as well as autosomal recessive polycystic kidney disease. In autosomal dominant polycystic kidney disease, outer contour is irregular. Cyst in liver, spleen, pancreas, diverticulosis, Berry aneurysm, mitral valve prolapse, everything is associated with autosomal dominant polycystic kidney disease. Autosomal recessive polycystic kidney disease, the outer contour is smooth. Microcyst or tiny cyst in corticomedullary junction is seen. Next, talking about acidosis as well as alkalosis, which consists of respiratory as well as metabolic. So normal things are pH 7.4 is normal, PCO2 40, that is acidic, and HCO3 is 24, that is base. So when carbon dioxide increases, it is acidosis, that is respiratory. When carbon dioxide is decreased, it is alkalosis, that is respiratory. When bicarbonate is increased, it is alkalosis, that is metabolic, and when bicarbonate is decreased, it is acidosis, that is metabolic acidosis. So, first about metabolic acidosis. Metabolic acidosis, pH is decreased, primary change is bicarbonate reduced, and compensation is carbon dioxide reduced. Metabolic alkalosis, pH is increased, bicarbonate is increased, carbon dioxide is increased. Respiratory acidosis, pH is decreased, primary change is carbon dioxide increase, compensation is bicarbonate increase. Respiratory alkalosis, pH is increased, primary change is carbon dioxide reduced, compensation is bicarbonate reduced. Next is a question. pH is 7.3, PCO2 is 35 mmHg. So likely acid-base imbalance is. So pH is 7.3, that means it is acidosis. PCO2 is 35 mmHg. PCO2, it is reduced. So this is metabolic acidosis. Next question, pH is 7.12, PCO2 is 50 mmHg, HCO3 is 28. What is the acid-base disease in this patient? So they are also asking the compensation. So here HCO3 is 28. So bicarbonate is high. When the base is high, it is respiratory acidosis with renal compensation. Next is about Winter's formula. Winter's formula is metabolic acidosis. Here the carbon dioxide is 1.5 into bicarbonate plus 8 plus or minus 2. That is the formula. Winter's formula, metabolic acidosis, carbon dioxide, which is 1.5 into HCO3 plus 8 plus or minus 2. That is Winter's formula. Next, about metabolic alkalosis. For every 1 milli equivalent increase of bicarbonate, increase carbon dioxide by 0.7. Now, respiratory acidosis, when carbon dioxide is increased, 10 millimeter increase of carbon dioxide. When it is acute, the value is 1, and when the value is 4, it is chronic. Respiratory alkalosis, when carbon dioxide is decreased, there is 10 millimeter decrease of carbon dioxide. So in acute respiratory alkalosis, it is 2, and in chronic respiratory alkalosis, it is 5. When pH is decreased and bicarbonate is decreased, it is metabolic acidosis. When pH is increased and bicarbonate is increased, it is metabolic alkalosis. Next is a case. A patient who is a known case of CKD came with complaints of vomiting. ABG report is pH 7.40, PCO2 is 40, HCO3 is 25, sodium is 145, chloride is 100. Here they are asking the metabolic abnormality. So here all the others are normal, but so with the sodium and chloride level we should calculate the anion gap. So anion gap, how to find is sodium plus potassium minus bicarbonate plus chloride. This is the formula for finding anion gap. Sodium plus potassium minus bicarbonate plus chloride. So normal anion gap is 12 plus or minus 4. That is 8 to 16. That is the normal anion gap. So in this question they have given us sodium and chloride. So in this question sodium is 145, chloride is 25. So 145 minus 25 plus 100, that is 20. 20 is the answer. So in this case 20 means it is more than the normal anion gap. So the metabolic abnormality is high anion gap metabolic acidosis with metabolic alkalosis. Anion gap is high here, that is here it is metabolic acidosis. Mainly in CKD patients with vomiting, uremia and all, it is high anion gap metabolic acidosis. If the carbon dioxide is high, that is hypoventilation associated with acidosis. If carbon dioxide is low, it is hyperventilation, that is alkalosis. Now about causes of HAGMA, high anion gap metabolic acidosis causes are drug ingestion. Drug ingestion, so drugs like isoniazid and salicylates are cause for HAGMA. Early usage of salicylates, it can cause hyperventilation, this can cause respiratory alkalosis followed by HAGMA. Shock with perfusion can cause HAGMA, it causes hypoperfusion. There is increase in serum lactic acid which causes lactic acidosis. In case of renal failure also HAGMA is the cause which increases the blood urea nitrogen as well as uremia. In case of hyperglycemia, there is urine as well as serum ketones present in case of diabetic ketoacidosis. In case of osmolar gap, when there is increased osmolar gap, there is methanol toxicity which we heard in Hooch tragedy. This is because of formic acid which cause vision loss as well as it is toxic to retina. And other thing which increase osmolar gap is ethylene glycol toxicity, which is an antifreeze agent. Here the calcium oxalate crystals are present in urine. Another cause of HAGMA is Kussmaul's breathing, which is a deep breathing to wash out the carbon dioxide, that is the acid. NAGMA causes are, NAGMA is normal anion gap metabolic acidosis. Causes are renal tubular acidosis. Renal tubular acidosis, there is urine anion gap positive. This NAGMA causes, there is hyperchloremic acidosis present in NAGMA. So first cause is renal tubular acidosis where urine anion gap is positive. In diarrhea, urine anion gap is normal. Carbonic anhydrase inhibitors causes NAGMA. Urethral diversion also there is NAGMA. Urethral diversion, it is seen in ileal loop. Here also there is NAGMA.